Hello, I'm very glad to be here with you. It's an honor to be here to talk to you about one of my passion. It's the primary care data and why it's a gold mine that it's unused. So I'm Professor David Darmon. I'm a professor in general practice, which is a real specialty, as my colleagues has to say. And I also the director of the Department of Education and Research for General Practice. And I'm also a co-director of Center of Innovation with for the partnership with the patient and the citizen. And the last line is that I'm responsible for a living lab of the European University Ulysses. Our healthcare system has to face some complexity. One of these complexity is that we are all getting old, older and older, for several reasons. The first one is that after the World War II, there's a lot of improvement in the healthcare, and mainly on the decrease of the early birth rate. And that's what we called the baby boom. Another thing is that we've seen that the infectious disease decreasing according to the all improvement in medical research, and also a decreasing of acute disease. And this for the profit of a real epidemic of chronic disease. Some may say that COVID-19 can moderate this purpose, but in fact, there is a real epidemic of chronic disease. And all the recent research found that when you are 50 years old, it's more common to have 2 chronic diseases at least than have non-disease at all. And that's a real challenge because it changed our vision of the care. I'm a general practitioner, and every day when I see my patient, and obviously when they are 50 years old or more, I have to think about what are the main problems that I have to take in charge in first. There are several problems. I have to see them in a global view, in a holistic view, with biomedical problem, social problem, psychological problem. And the fact is, with all these different kinds of problems, I have to look at the different guidelines, the recommendation that our institutions, such as the HAS, la Haute Autorité de Santé, gave me. And these guidelines are mainly based on studies on hospital data. And all the patients that are selected in these studies are strictly selected so that the studies can give some positive results. So in fact, the data that we use for the recommendation are not the best one to help me in my daily practice. There's several studies that show that when 1,000 patients are exposed to a risk to one disease, we have 750 persons who report the symptoms, and usually they are doing auto care. They will manage themselves all by themselves. They are searching information on internet, and they will try to care themselves. But 250 patients are going to the primary care practitioners, so general practitioner usually, and only one is going to the teaching hospital. According to what I said just before, it means that all a global amount of the data that we used in the research are based only in this patient who is going in the teaching hospital, which is not representative of our population. So the good news is that we need primary care data. Sorry for the mistake. To think on real life data and to fit our care on the real need of the population to conduct a better health policy, a better quality of care, to have indicator of epidemiology, and also to have a better research according to the real need. And that's what we need to enter the 6P medicine. Maybe you already heard about this concept, which is a medicine predictive, to avoid the complication, participative, to decide with the patient, predictive, to anticipate a disease based on evidence, or real evidence. Personalized, that means that I can use data from public health research, but I really need the best data for the patient that I have just in front of me. And also to imagine with them what will be the care pathway for this patient. So that's why we need primary care data. The really good news is this data exists. In fact, every day, each general practitioner in France doing 2 million of consultations. For each of these consultations, they will record the reason for encounters, the diagnosis, the main reason why they are coming, and what the expertise of the general practitioner can focus on the diagnosis. And also, what is the plan of care? What we are doing for the patient as a prescription, biologic test, drug prescription, etc., etc. And the fact is, the electronic medical record, the software that the general practitioner is using every day in this practice, is the way they collect this kind of data. And so that's why these data are a game-changing research resource. And most of all, when you look at all the data in medicine, they are holistic data because they address biomedical data, social data, and also psychological data. So after this state of art, let me introduce some proof of concept that we lead. We set up a practice-based research network, which means that we have 30 GPs who collect data. It considers 1,600 patients and over 1 million of consultation. We used this data for one example of application in artificial intelligence. We tried to predict what is the risk of hospitalization according to the data. So we used the data in primary care to try to determine what is the risk of hospitalization. And so it was a project that I lead with my colleague Félix Kudelka, and also the INRIA and ITRAZES, the same actors that you've seen before. And what was the result? It was this one. We created an interface which can show to the patient what are the factors which are lead to the risk of hospitalization. And we showed to the patient which are the factors that we can change to reduce this risk of hospitalization. So we learn about the risk of hospitalization according to the data, and we discuss with the patient how to change their lifestyle to decrease the risk of hospitalization. That's one of the use that we can do with this data. We also worked with Canada during the COVID epidemic to predict what are the cases of severe disease in COVID. And there's plenty, of course, of different applications. So to face this challenge, I'm very proud to announce the project of the creation of the Institut des Données de Santé de Ville. So in English, it's slightly different. Institute for Primary Care and Health Determinant Data, which is the project that we conduct with University Côte d'Azur, Cluster IA, the 3EA, which is the Institute of Intelligence Artificielle, and with a continuous dialogue with the Metropole of Nice Côte d'Azur, the creation of a data warehouse which collects primary care data from the consultation, environmental data, and data which are coming directly from the patient. The thing is, we think that when you collect all this kind of data, you are able to determine what is the exposome, which means the different kind of determinants who can weigh on the result of quality of care. This institute is a part of a living lab, which is included also in the Ulysses European University, which is a consortium of 6 different universities. Université Côte d'Azur, of course, but also University of Geneva, Košice, MCI in Australia, Agalia in Finland. And we have the role in this living lab to help people to create value on usage on the data. So the thing is, we will propose in this institute to give a real ecosystem to make the link between the technology suppliers, which can be researchers or company startup, who have proof of concept, to help them to describe, to learn, and to innovate and improve their concept by make participative research with users, which can be patients, citizens, healthcare professionals, but also to make them in link with the financiers, to help them to access to the public or create startup, and academic to give real good evaluation, an academic evaluation, and also an academic evaluation in scientific area. We'll be helped by the cluster here to give an expertise on all the artificial intelligence modelization, but also in the animation with the cluster ER. And so I finish. So please join us. And if you have any question, even in French, I will, of course, respond. And I was very happy to talk to you about that. Thank you.
Any questions? I find it quite interesting that Australia wants to be in Europe so much that it's in this university.
Austria, sorry. Austria.
Okay,
Austria.
I was like, they're already in the Eurovision
No,
Song
Austria.
Contest, so, okay, cool.
Sorry.
Okay. Can you tell us a bit more about, so you're presenting this to patients in a very transparent way? Because usually when you come face to face with your GP, he or she tells you what to do and you follow the instructions. So is part of this making healthcare more transparent and encouraging patients to understand for themselves the reasons why what they do won't lead to them becoming more sick?
The thing is, this project is real to make and link the different actors. So we are thinking, thank you, in the model of Montreal, which is another way to see the interaction between healthcare professionals and patients. Before, as you said, the doctors say to the patient, you have to do this and that's all. There's no dialogue. After that, we were patient-centered, which means that everybody in the healthcare team will do things for the patient, but it's different to do something for the patient than with the patient. So we change the concept in the way that the patient is a part of the healthcare team. So you cannot ask to a patient to do something if he doesn't want, if he doesn't fit to what are this representation, the way of seeing the life. So we need just to give him the best information according to who he is really, and to have more personalized data to help them to choose wisely, in fact. That's the aim of the whole project, to improve the healthcare system.
It's their bodies, after all. I suppose that would be the argument, and I think that's very interesting. It's an approach in France that not all countries share, and I think it's really interesting. Anyone else got any questions? Okay, well in that case, thank you very much for your time, David Darmon.